So one of my favorite collaborators in the world of cancer care, colorectal cancer primarily, over the years has been Dr. Tony Bach, who, as you heard, has moved from the Seattle Cancer Care Alliance over to Harborview to work in the area of palliative care. Tony did his training at a small university south of here, Stanford, you may have heard of it. An even smaller one on the East Coast, Harvard, you may have heard of that too. Despite those bad influences, he came here and has done very, very well, and created a wonderful perspective that he's going to talk today with us about serious illness, bringing that cancer and that palliative care perspective and a patient focus that is so valuable. Tony?
Thank you. Thank you. Thank you, Dr. Sinanen. And for me, it's a special pleasure to be introduced by Dr. Sinanen because he is a surgeon par excellence, and I have always so appreciated his willingness and commitment to explaining things to patients in a way that they can understand. It's really an amazing quality. I am going to take the opportunity to follow up Randy's talk, which gave you a great picture of the lay of the land in palliative care, and talk about something more specific. Because I think all of you are here because many of you have had some experience with serious illness. Is that right? Could you raise your hands again? How many of you were directly involved in the care of a family member or a close friend who was involved with that? And how many of you then had to help with making medical decisions for that person? Yeah, almost the same. And then finally, how many of you faced a certain amount of uncertainty with that? Unclarity, wondering what the right thing to do is. I think that is really the commonest challenge that people face when they're dealing with serious illness. And what I wanted to address was this issue, which patients ask me all the time, which is, why should I talk now? Couldn't I just wait until I really have to talk? It's so hard and awkward to talk about this. I don't really want to do it unless I'm forced to. I am going to make a case today that talking now, even if you only talk a little bit, matters a huge amount, and it can completely change the kind of care that you and your family get. Because even if you have a terrific doctor like Dr. Sinanen or Dr. Curtis, there is no substitute for you and your family having some conversation about what you would want if your illness were really serious. And I don't mean that you have to know every piece of what happens in medical care. You just have to know what's really important. And I'm going to illustrate this with a case. This is a friend of mine. Her name is Katie Butler. She wrote a book because she is a journalist about her experiences with her mother and father. Being a crack journalist, she is really good at searching the literature, and so she got her father and her mother, when they needed it, basically the best medical care you could get in the United States. And being a blazingly honest person, she also was really clear about the fact that even though she tried really hard with her father, he did not get, in the end, the kind of care she was hoping for. And that's what her book is about. So if you haven't seen this, it's called Knocking on Heaven's Door, The Path to a Better Way of Death. It is an amazing look at the American healthcare system and an amazing look at what patients and families face when they're dealing with a serious illness. It was a New York Times bestseller. It's just come out in paperback a little while ago. And I'm going to tell you a little bit of her story because it's public record and because it's one of the very few public stories where people talk about going in with really good intentions and having it not come out the way they hoped. So here's Katie in the middle. You can see her mother on the right, her father on the left. Her father was the one who got sick first. He was born in South Africa. He lost his left arm in World War II. He went to Oxford and got a PhD. He became a professor at Wesleyan University on the East Coast, and then retired. He was having an active, wonderful retirement when he collapsed on the floor at age 79 with a huge stroke, and ended up in the hospital for 6 weeks. She writes, he came home 6 weeks later, permanently incapable of completing a sentence. But as I've said, he didn't give up easily, and he doggedly learned how to fasten his belt, how to pick out sentences on his computer, to walk alone, even though he was dragging 1 foot, to the university pool so that he could go to a water aerobics class. He never again put on a shirt without help or looked at the book he had been writing at the time of his stroke. One day, he haltingly told my mother, "I don't even know who I am anymore." I mean, this was a devastating stroke. And his stroke devastated 2 lives. Before then, she was a housewife who practiced calligraphy in her spare time. After that, she was basically a one-woman caregiver who bathed him, showered him, fed him, took him to his doctor's appointments, and it was a full-time job. Her blood pressure went up, her weight went down, her internist decided that she was depressed and offered her antidepressants. Her father came to believe that his wife would have been better off had he died. He told Katie she would have wept the weep of a widow, he said in his garbled post-stroke speech, and then she would have been all right. And Katie writes, it was hard to tell which one of them was suffering more. One of the key decision points came up when he had a hernia. He went to see a surgeon to get what was a small operation, but the surgeon noticed that he had a really slow heartbeat and wanted to put in a pacemaker. In his post-stroke state, Katie writes, it's really unclear that he really understood what he was up against. And so the decision fell to my mother. She was anxious to relieve my father's pain, exhausted with caregiving, deferential to doctors, and no expert on high-tech medicine. What do you do in that situation, right? And this is the classic situation that families find themselves in. They have to make this really complicated decision. It's really emotionally loaded. And she did what any wife would say. She said yes, right? She said yes, hoping for the best, and this is what happened. The pacemaker brought my parents 2 years of limbo, 2 of purgatory, and 2 of hell. It turned out he continued to have strokes, fell on the sidewalk, had a brain hemorrhage, and really became unable to take care of himself. There were a whole small series of medical decisions that got made after that, but the pacemaker was still going, and it seemed like the medical machine just did the next thing that would keep him alive. And as Katie writes, no one ever had a conversation. No medical caregiver had ever sat them down to say, if this pacemaker works the way it should and keeps your heart going for 10 years, do you really want to spend 10 years in this almost mute, incredibly physically debilitated state? It seems clear to Katie that he would have said no had he been able to have that conversation, and yet it just never came up. Eventually, he died after a long, prolonged period where he was screaming at his caregivers, screaming at his wife. Katie said it was a nightmare, and the whole death was kind of a nightmare. And it left their entire family shaken because they felt like they had tried to get the best American medical care could offer, and yet what they ended up was, 2 years of limbo, 2 years of purgatory, 2 years of hell. How unusual is this? Well, it turns out this is not as unusual as you would think. And that's one of the reasons we are working so hard on this Center for Palliative Care. In the United States, in 2015, there will be 2.5 million deaths, right? 85% of the people who die will be over 65 years of age. I mean, that's, what you would expect in an industrialized country with, very good health care. So that's 2.1 million people. Of those 2.1 million people, 70% will be unable to make decisions for themselves at the time of death, and they will be relying on people like you, people who are their friends, people who are their family, people who care about them and know them. And because those patients will have doctors who turn to people like you who care enough about them and are trying to help. That's why it's so helpful for you to know something about what's important to them. As I said, you don't have to know all the medical details, but what you do need to know is, what makes life worth living for somebody? And can you start to talk about what is really important to people? This is the question that Randy raised earlier. What's really important to you now? It turns out Americans are all over the place with this kind of question. And there's a lot of data to suggest that what Americans really want to have happen is not really what happens. So in this poll, I'll turn down the lights a little, 90% of Americans say talking about end-of-life care is important. 27% have done it, right? If you ask them the statement, if I were seriously ill, I would talk to my doctor about end-of-life care, 80% of Americans agree that they would do this, only 7% have done it. So there's a huge gap in terms of, what we think should happen and what actually happens. What happened to Katie's father? I mean, he just moved through a whole series of specialists. And, there's studies that show that Americans within the last 6 months of life are seen by more than 10 specialists. And what that means is it's incredibly important to have a primary care doctor who is the quarterback of the whole team. And it's really important for you as the family to know and to be able to talk about what's going on. The big issue that I see with this particular case is that the care that Katie's father got did not match his values. He was an independent gentleman. He prized himself on his intellect. If he had known that he was going to be living for the last few years of his life in a debilitated state, running his wife's health into the ground, he would have clearly said no. And yet, that's not what happened. How do we change this situation? I thought I would start with just a little bit of work from you guys right here. So I'm going to ask you all a couple of questions that are on the conversation project and see what you all think. So here's the first one, because good intentions can result in care that is not so good. Oh, I have one more anecdote. Here's the other piece that comes up in the paper all the time. When cancer treatment offers hope. This is a story from the New York Times just earlier in the week. And Mikhail Sakiris is a leukemia doctor at the Cleveland Clinic. He writes about talking to a patient who said, the only hope I have is another treatment. And so he writes about how, as a doctor, he felt like, well, I don't think another treatment is really going to help, but I feel like that's what she wants, so that's what I should do. That's what this article is about. And I get it that he felt really pushed to try and provide one more thing, but in fact, what he's doing isn't what she's really hoping for. It turns out that choosing hope and giving another treatment as an oncologist means that that patient is more likely to have CPR right at the time they die because the CPR is not going to work. It means they're more likely to have a feeding tube placed, even though it means they won't live longer. And it means they're more likely to die in an unwanted place, meaning more likely to die in a nursing home or a hospital or in an ICU. And so that's the part of the hope that I think doesn't always get talked about in these conversations. And it's a huge issue. Even the chemotherapy that this doctor is talking about, is fraught with a kind of double-edged meaning. For that patient, choosing chemotherapy at the very end of their life doesn't mean that they're going to live longer. Actually, it probably means they're going to live shorter, because if your body can't take the chemotherapy, if you're not strong enough, it probably does more harm than good. And that, in a way, it sounds like common sense, but that's the kind of thing we are starting to learn in the kinds of studies that Dr. Curtis was talking about. We can actually start to see when more technology starts to do more harm than good. And that's why it's so important for us as physicians and nurses and you as family members and patients to have this really careful dialogue about what to expect and what we can really hope for. Because I think what the Katie Butler story tells us is there's a time to really push and try new treatments, and then there's a time to back off and start to think about, what do I want to do with the life I have left? What happened to Katie's father is really common, but you can avoid it. That's the point of this talk. Katie's mother, it turns out, took a completely different path than her father did. Here's her mother. It turns out after a few years, she started to have her own heart problems and needed to go to see a cardiologist who recommended that she go see a heart surgeon. The heart surgeon said, "Why are you here?" And she said, "To get my questions answered." Because she, as Katie puts in her book, was no longer a trusting and deferential patient. In fact, by that time, she had a great deal of suspicion about what was being offered to her. And when the cardiac surgeon talked to her about a high-risk surgery that would leave her with a very significant chance of cognitive impairment, a significant chance of ending up in a nursing home for the rest of her life, a significant chance of dying, she said, "No thanks." Went home, lived at home for another 2 years, and eventually went to hospice. And as Katie puts it in the end of her book, my mother died shortly after her 85th birthday in a quiet hospital room in Connecticut. One of my brothers was down the hall calling me in California to say, too late, that it was time to jump on a plane. We were not a perfect family. She did not die the perfect death, but she died a good enough death. Thanks to choices she made earlier that seemed brutal at the time. And my hope with this, and my hope in giving this kind of talk, is that we could turn that kind of conversation from feeling like something brutal to feeling like something all of us should be engaged in as people involved in healthcare for people that we love. Because it's, as Mary Oliver puts it, the poet, tell me, what is it you plan to do with your one wild and precious life? There are a number of things that happen when people are able to face up to these kinds of decisions. I mean, here's another patient of mine whose name is Yoshi. He had dementia. His family made a very courageous decision to take care of him at home, not to put in a feeding tube. They had the talk about whether life was going to be worth living like this from a very early time in his dementia course. And when the time came, they decided to take him home, keep him there, keep him really comfortable, not do anything to prolong his life. And his wife told me later that it was one of the most intense, beautiful times that they ever had together as a couple. It's not that there weren't some really bad days, but, he died at home, the family was around him, and his 12-year-old granddaughter made this is part of the memorial card she made for him, because she was part of the whole process and saw this. So it says at the bottom, a man of many colors, an inspiration to all of us, and those were some of the things that he loved, his glasses, his chocolate, his coffee. And that's actually a photo of him right after he died. So actually, the things that become possible when a family and a patient can really face this together, I think are quite remarkable and are huge teachings for all of us about, what it means to live in this kind of human body. So here are the questions that I promised you. So I'm going to ask you to answer these and then, turn to the person next to you. The medical information I'd like to know. Are you more like this end, I'd like to know all the details about my condition, or are you more at the other end? I want to know just the basics. It turns out there's no one right answer to this, but the reason it's really helpful to know what your family member thinks is that if they're over here, then you won't keep torturing them if you're over here, right? Because it turns out that is the basis of a huge number of slight arguments that I see in the waiting room, and a huge issue about unhappiness because people feel like they should be in the same place when all the research shows that they're just not. So where are you? Are you here? You here? Are you here? Please turn to the person next to you and talk about that for a minute. Thank you. So would anybody like to say where they stand? We have a couple of people with microphones. Would anyone like to say, you can just tell us, thank you. What's your preference?
So I am an information gatherer. So in everything in life, I'm a 5, maybe a 6.
A 6.
So, but a question I have for you, which maybe is not appropriate right now.
Yeah,
but
that's okay.
What happens? Like I am a 5. I think maybe one of my parents is maybe like a 2 or a 3. But what happens if the roles reverse? So I'm the patient and I'm a 5, but my caregiver or closest family member is a 1.
Yeah.
What do you do about that?
Yeah. Well, so there might need to be a little negotiation. And, I commonly find that different people in the family need different kinds of conversations. So sometimes I'm having separate talks with people. There might be somebody who feels really fearful about hearing all the details, or it just makes them crazy, right? And there are other people who really want to know all the details because it actually helps them settle down because they feel like they're on top of it. And so I think it's our job as the clinicians to figure out who needs what and how can we give people what they need and not force the family to all get the same thing when it's not going to serve them all, right? That's a great question, though. Thank you. Anybody else want to comment on where they stand on the scale? Who else would like to say? Yes, you up there. Thank you. And then I try next. Thank you, sir.
I think I'm a 5 mainly because it's this is where the rubber meets the road with the number 5.
Yeah.
I mean, you can't, you don't know if you can run the option if you're number 1.
Oh,
you gotta be number 5.
Good question. So this is such a great point. So I do think that there are people like I didn't catch your name, but Ms. Number 6. Who really feel better if they get information, right? They feel better and they settle down. There are other people who it makes them a little crazy. So here's what I'd offer is, you do need to get the information that you need to make a decision, but sometimes that doesn't mean you need every detail. You might need just enough information to make the right decision, and if you find a doctor you can trust, you can make a decision and not have every detail. That is really okay. And I would say it's up to you to figure out with your doctor, what's the right mixture of information, what's the right level of detail. But I don't think you have to feel like you need to hear about every detail. Listen to yourself and where you are in terms of being able to make a decision that you'll feel comfortable with and won't have regrets about. And if it's every detail, no problem. But if it's not, don't beat yourself up trying to learn all the details, right? It might not help you. Okay, here's the next one. Okay, this is harder. I'll just warn you up front. Where would you prefer to be in your last days? Okay, if you're on a 5, this one is, I want my last days at home, or here, I wouldn't mind spending my last days in a facility. Can you turn to the person next to you and talk about that for a minute? Ooh, this is harder, I know. Thank you. Does my microphone work up here? Does my microphone work up here? Every time I walk up here, it feels like it does. Okay. Were you over here? Or were you over here? Would someone mind volunteering something about what they talked about here? Would you mind volunteering? Oh yeah, thank you.
Call somebody else.
Oh.
Me?
Yes.
Okay.
Please, thank you.
So I'm a caregiver for my mom, and we're taking care of her at home. So I know that her preference is to be at home. She's
Yes.
already at a really chronic state. So I see the importance of getting palliative care input at this point to understand fully the dimension and the capacity that we'll be able to keep her at home
Yeah.
to the duration of her life. So
Yeah.
this is so relevant to, know this,
Well-
but also understand how you can continue to provide that care at home in
Yeah.
the best way possible.
Well, thank you for everything that you are doing. I mean, you are the kind of family caregiver who makes that possible, and it is a huge amount of work, so thank you for that. It's pretty amazing. Anybody else? Yes, in the back, thank you. Thanks, Leonie. Yeah.
Discussing different definitions of home.
Oh, yeah.
And
Great.
like, I don't really have a preference between a facility or home. It's more so about the people that are with me.
Yeah. That's a great point. It might be that home is who is with you, and the physical surroundings aren't that important to you. And so if you're with a family member or you're helping someone make medical decisions about that, that's actually a hugely important thing to parse out. One last one. Any last? Yes, over here. Sir.
A little over a year ago, my wife died at home.
Oh.
And that was a good experience as far as, aside from that, Mrs. Lincoln, how was the play?
Yeah.
But I've visited people in hospice settings where they had very nice facilities and everyone was able to visit and come, and because they had special needs that couldn't be taken care of at home,
Yes.
it was important for them to be in that situation.
Yes. So, what you're saying is absolutely right, that the polls show that most patients, most Americans would like to be at home, and there are a small number of people who have medical needs that really do better in some kind of hospice inpatient unit or in a hospital sometimes. I think of that as the kind of thing that we can do if we need to, but knowing somebody wants to aim for home helps us arrange their care in a whole bunch of other ways. So I think you're right. It needs to be there if we need it, but lots of times, we can actually get you what you need at home. And if you want to be at home, and if you have a family who can help you, that can really be a terrific thing. So I think I have one more here. Okay. How long do you want to be treated medically? Length of life is more important, even if I'm uncomfortable, or at some point, quality of life is more important. Where do you stand on this one? Do you stand over here? Do you stand over here? Where are you? Let's talk about that for a minute. This is the hardest one. Ready? How many of you put number 1? Can you raise your hand if you put number 1? 1. No takers for. What about 5? More of you are 5s. Okay. 7. Okay. I think I'm going to have to talk to Dr. Curtis about doing some more work on these measurement scales. I don't think we're doing it quite right. Anybody want to comment on this? Yes, sir, in the back. Thank you. Thank you.
Yeah, my wife and I were talking here about a friend of ours who was a world-renowned orthopedic surgeon who, before he got ill, definitely would put everything over on number 5. As soon as he got lung cancer and went to a slow, painful death, he was way over on number 1 and wouldn't change.
Oh, that's so interesting. Well, so here's one of the things, and I think your story illustrates this. People start at one place, but after they get sick and when people get a serious illness, sometimes they change and move around, and we can't predict it. So having a conversation now doesn't mean that you're locked into whatever you decide now, because we never know how things are going to change, and we never know how our own coping will be. But being able to talk about this now means that it'll be more likely that you can talk about it when the time comes, and more likely that you'll be able to settle down and have a serious talk instead of just being overwhelmed with the moment. So that's a great point. Thank you. Any other comments on this? Anybody else? Yes. You can go again. You can shout. Yeah.
I would say it depends on, for me,
For you.
I have one of my 2 kids at home. So
Yeah.
I would walk through fire to stay alive long enough to see my son graduate from high school and then maybe beyond.
Yes.
But if I'm older and I know that my kids are okay, then I think it's easier to say, I've had this good life, my kids are okay, and I would
So I'm going to repeat a little about what you said. She was saying that if right now, if something really serious happened to me, I would want to make sure my kids are taken care of, and I would walk through fire to make sure my son got what he needed, right? On the other hand, if I were older and my kids were okay, I might feel differently about it. And so, you know, what you're illustrating here is something we see all the time, is that what influences this decision isn't just about you, it's about what you are responsible to do and what your mission is in life. And to me, that wanting to walk through fire for your kids is just as legitimate as, you know, I'm 80 and I've had a great life and I think I'm ready and I don't want to end up in a nursing home, right? So I think this is where we as doctors need to be sensitive to what happens through the life cycle with people, because as you go through time and you change, you know, your answers to some of these things might change. And again, it's being able to have this conversation. The more you talk about this, the more you'll be able to deal with the changes that you have in your own life and the ways that you look at your own health care, because they should be different. We're just different. So you've already done this. So I'm going to really end with, were there any last questions about this? I've given you 3 of the questions from the conversation project that Randy mentioned. If you go to that website, there are a bunch more. And I think there's some great conversation starters for you to have at a kitchen table with some people that you care about and care about you. But as you can see here, it's not totally simple, but it's totally doable. Right, you did 3 of the hardest questions in the whole guide right here, and it sounded like there was a lot of great discussion going on. Did you have a question? Yes.
I was going to say one.
Oh, Leon, can you do is there a microphone person still here?
I have a loud voice.
Okay.
I was thinking that often when you are a 5, the caretakers, the doctors that you speak to, sort of talk you into going for the treatment.
Right.
Isn't that a case?
Well,
most
what
of the
happens,
time?
yeah, so you want one thing and you feel like the doctors could talk you into something else. Is that right? Well, so here's the thing. If you feel like the doctors are talking you into something else, it is totally fine to say, I don't think I can decide today. I think I want to think about this and talk to you again. Because here's the thing. Not all doctors are really good at doing this, and you will have to find some people that you can talk to. And one of the key things when you have a serious illness like this is figuring out who's the doctor who will really listen to you, understand you, and match up what's possible medically with what you are trying to do and what's important to you. Yes? So I think it's totally fine to say, hey, I need to think about this. Yes, you have a question.
I guess this is a continuation of the question, how do you get your caretakers to take you seriously and to abide by your wishes? Like my grandfather, he had a living will, he discussed it with his family. We all had decided. He had severe dementia, was in a nursing home my grandmother could no longer care for him. And he had pneumonia, and he was dying, and he was miserable, and they were pushing antibiotics, and they wouldn't stop. They wouldn't stop all of these treatments that none of us wanted. And my mom and one of her brothers were visiting, and they went in to talk with the administration. The administration didn't want to budge. They had my uncle on the phone who's an anesthesiologist, and they had to threaten to move my grandfather to another hospital facility. And finally, they would abide by my grandfather's and our whole family's wishes. But I mean, once you're in a hospital, you're not under the same care as you were even in a nursing home necessarily. So are there better legal measures people can take to ensure that what they want happens?
Good. So first, that's a horrible story, and I am sorry that that ever happened to you, because it's the kind of thing that shouldn't happen to anybody, right? And yet, it's some of the things that we're still struggling with, because everybody in our culture is struggling to come to terms with, you know, what happens and how do we recognize that somebody is really at the end, and how do we do justice to that in a dignified way? It's a tough situation. I would say that I think that it's slowly changing, but it sounds like you have another comment also. Yes.
I'd like to suggest that it may not have been concern for her family member, but it may have been the profit motive that was driving that. I think profit plays a huge role in these situations.
Yeah. Well, you know, there may be all kinds of things that go on with these things. And I do know that there is, for some clinicians, just this huge discomfort on recognizing that the time has really come. Yeah.
Just want to start with thanking you for this. It's been really informative, and I'll be sending this to my parents to watch. But one of the interesting questions I have, which is, when you have this conversation early and you don't actually know what will happen, how do you build a framework that will survive first contact with what actually happens?
Yeah. Great question. Well, so that's why his question was, how do you build a framework for what's going to actually happen when you don't know what's going to actually happen? Well, that's why I think some of the most important questions are, you know, what's important to you? What makes life worth living now? Where would you like to be when your time really comes? Because those are questions that go across every disease in every situation. And one of the reasons that we find that asking the what's important to you question is so key is because as a doctor, if I know what's important, if I know that, you know, his friend wants to be able to watch sports, you know, I can adjust his medical care and figure out where a place that he can watch sports is. If for somebody else is, I need to be in a place where I can go outside once in a while, I can help arrange that. And it might be at home or it might be in an institution. But that kind of information about what's important is really critical. That said, I mean, these conversations are going to have to be revisited when big things happen, because things change. There are always things we can't anticipate. And I don't think you should be spending all your time trying to prepare for the worst possible outcome, right? I mean, we've got to live our lives. And yet, knowing some of the big goalposts about what's important can be such a huge benefit when you get to those time points. So it's a little both. Yes?
A wonderful presentation. Like 2 years ago, you mentioned about the change the culture, about the cancer care. So you mentioned about that in that lecture. You just mentioned about the sometimes in most of the case, the doctor think the patients got it, and the patients think, oh, maybe my doctor totally understand me. So it is really hard to build kind of like the balance about the communication through the patient and the care team or something. So my question is like, what is the most challenge for the hospice care and the end-life care through the patient and the physician team, please?
So you know what? So what you're referring to is I gave a talk a couple of years ago, where here in the mini medical school, where I talked about some of the things that studies that show that doctors say things and patients don't hear it all, and so one of the challenges is how to figure out what someone has taken away and where someone is in the moment. I think, you know, when it comes to this kind of case and making decisions about how much more care to have, or or if there's a decision about hospice and whether it's time for that. I think the most challenging thing is to make sure that I understand where the patient is, that I understand where the family is, and that I can communicate with them about, what I think is medically possible, and what I think is, I would recommend based on what I know about that patient's wishes and what I know about their medical condition. Because I feel like as a doctor, that's where I really add value. I have a bank of clinical experience that I try and draw on to help patients make good decisions. And that's something you can't get from Google, right? Not yet. Thank you. Yes.
Hi, I was really touched by those 2 slides that said, I would like my doctor to bring this up, and then the other slide, well, I would like my family to bring this up, right? It's this dilemma of who is going to speak about the issue. So I bet the people in the room that have faced serious illness, either ourselves or our family members, we probably have already had these discussions. But if I think about young medical students, I'm wondering, how do you teach this? I wouldn't say it's a new concept, but it's probably not something that I would read out of a textbook. It may take a lot of practice to actually talk about something that maybe they didn't go to medical school for, right? They're young, they think, life is amazing, I'm invincible, I can cure this, but you want them to step back and be able to discuss that. So that's my question.
One of the big things that we have done in our research, and this is research from the Cambia Center of Palliative Care, can I show a 2-minute video? Sure. Is how do we actually train physicians to do this? So I was going to say, the other side of my work is about how do you train clinicians to actually do this kind of conversation in a way that helps people make good decisions. And what I'll do is I'll show you a little video that is about one of the courses that we do for physicians. But I need sound. Uh-oh, do you know what happened to my sound? Huh. You know what, I'm getting this sign that I can't turn the volume up. Huh. Okay, well, I'm sorry. I guess we're not going to show that. But suffice it to say, we have done a whole bunch of things. Written a book, done some e-learning, written this app, as ways to train people in the kind of communication skills that they need to do this. Because it turns out you can't learn from reading in a book. You have to practice. And we have people practice with actors. We have them be supervised with patients. Their whole array of educational things that we do, starting in medical school and all the way up through practicing physicians who are trying to learn to do this, because most practicing physicians did not learn how to do this during their training. Ooh, can I do one more? Where are we? Yes.
Okay, I had a question about how you go about identifying the need at the point at which you need to bring up the question of palliative care with a group of a patient at the point when they first come in, and they've, particularly somebody that's older. So if you could talk about that.
Things that make me think that more palliative care is useful. One is somebody has very significant symptoms that have been a little tough to control, right? The second is somebody has really complex medical decisions to make and needs to really think it through. The third thing is if somebody is really sick, really sick, and it might be time to talk about something like hospice or talk about something like changing their goals of care. I mean, I think all those things are times when a palliative care clinician can be really helpful, and that if you are with a family member in a hospital, you shouldn't hesitate to ask if there is somebody from palliative care who can help with any one of those things. And they don't have to be dying, right? Symptoms, complicated decisions, those are things where palliative care really adds value right now.
So what I'd like to see is have the system set up so that happens, that you don't have to have a family member or something there to intervene for you, because while some of us were there for our parents to do that, if we don't have children or we don't have children around or that sort of thing, you know, who's going to be there for us when we need it?
Yeah, I hear you. And actually, that is one of the reasons we're setting up these systems in hospitals, to make it more automatic so that you don't have to ask. Yes.
Last two questions.
Hi. I'm curious, given that we're in Washington State, does the topic of assisted suicide ever come up in your palliative care discussions, and how does that come up?
Yeah, you know, so Washington State is one of the states with the death with dignity law, and so under that law, a patient who is able to make decisions, who has a life expectancy of less than 6 months, is able to get a prescription for medication that will hasten their death. You know, it turns out that that is an option that very, very few patients really want to do, even though many patients want to ask about it and talk about it. And so in Washington State, it's much fewer than 1% of deaths happen through the Death with Dignity Act currently. And you know, in states where it's been around for longer, that rate has been very stable. I think this issue gets a lot of traction and a lot of press because it's a different kind of story about the end of life. You know, one where I've taken control, and I think that's very attractive to a certain number of patients. And so it's certainly something we talk about with patients because it's a legal option. And yet, it turns out that not that many patients really want to do it when push comes to shove. Thank you. Yes.
Hi, I actually work at the medical center. I'm a nurse on one of the cardiology units. I wanted to answer your question, actually.
Oh, sure, thank you.
In our admit process work on our floor, I'm pretty sure it's hospital-wide, there is a section where you ask, would you like to receive palliative care? So that is good that we asked that question, but recently my floor just did a little EDU day where we actually went into depth on what palliative care is. And we found that a lot of our staff didn't actually know, and it was considered a step you take when you're at the end of your life, and that's when you need to consider palliative care.
That's right.
And so I think it's really necessary for hospital-wide that the staff gets the education necessary to know that this is something that starts at the very beginning of your treatment. You can have this anytime you want.
That's right.
And it can be very beneficial to you.
Yes.
So we do ask that at admission, but I think people get scared by that question, like, I'm not dying.
That's right.
So it needs to be something where the staff has the language and the terminology to be able to discuss what it is and how it can be beneficial to them. Secondly, on our floor, palliative care is an automatic consult for people who are receiving advanced heart failure therapy. As soon as they're said we need advanced heart failure therapy, they will receive that consult. Is there anywhere else in the hospital that is getting that automatic consult?
Not currently. I mean, there's some other kinds of things where we are starting to experiment with services like that, but it's a great example of where we can arrange the healthcare system so patients get offered that at the time they need it, whether or not they know to ask for it or not.
I think that's also very, very beneficial,
Yeah.
especially with discussing those questions that you had on the board. Not a lot of, like when doctors are coming in at 6 a.m. and rapidly doing rounds,
Right.
a lot of patients aren't in a position to ask these questions or be asked, and a lot of nurses don't have time. So I can't say how important I think it is for palliative care specialists to be available at all times and for patients to have enough education to know to ask for it.
Yeah. Well, thank you. Wow, you're like a plant. I'm going to thank you hugely. And if you have other questions, we'll be down at the front. You can help us by joining our advisory board or supporting the center in some way. And so if you have questions about that, we have some more information and some phone numbers down here. So thank you very much. Thank you.